Теперь мы переходим к следующему докладу. Доктор Matthias Грисхабер, доцент и консультант офтальмолога университетской клиники отделения офтальмологии города Базель, Швейцария. Современное направление хирургии глаукомы без создания фильтрационной подушечки. Пожалуйста.
Dear colleagues, Professor Bikoff, I'm glad to speak here about bleb-less glaucoma surgery. And I'll mainly cover non-penetrating procedures, which I'll show you in a few minutes. Well, the common goal of modern glaucoma surgery is basically to avoid, as we heard earlier, complications. And the procedures I'm going to present, they try to restore the natural outflow system without creating a bleb. However, it is not the goal of these procedures to equalize the efficacy of trabeculectomy. As you know, by creating a full thickness hole in the eye may lead to pressure down to zero, with the subsequent complication we don't want, such as hypopnea-related complication like glaucophy or early development of cataract, which is particularly bothersome in the younger patient. So I will talk about the more established ones, procedures. We heard already the gold jump before. So I will talk about the trabectome and the microstent, which are in the category of ab-internal procedure. And then later on the ab-external procedure, which I've talked in part last year already. Trabectome trabeculotomy uses a high-frequency electrocautery to ablate the inner wall of Schwann's canal. It is usually performed through a clear cornea incision from the temporal side, and up to 120 degrees of trabecular meshwork is removed in order to create a cleft for a direct outflow of aqueous from the anterior chamber into Schwann's canal. Maybe we can show a small video here on the top right, if possible. If not, we continue to the next slide. Regarding the results with the trabectome alone procedure, we get a decent IOP reduction to about to the mid-teens, in 14.2 and 16.2, 6 depending on the studies. We get a further IOP reduction in combination with phacoemulsification, up to or down to 13.5. There's a large numbers of eyes included in these reports. However, these are all retrospective data analysis from the company, so these results also have some limitations. Regarding complication, common complication, if you call it a complication, is high fever. Because it just shows that you have opened the inner wall completely, and there's a blood reflux from the episcleral system into Schwann's canal and anterior chamber. There are, however, no common complication which we know from fistullating surgery due to the approach. The second one, the eye stand, is a titanium single piece shaped implant, which is probably the smallest implant in the human body. It is 1 millimeter in length, it has a diameter of 120 microns. And again, it is performed through a gonioscopic approach and is inserted into the nasal angle of the eye. Interestingly, although it's very popular, there are not so many data available yet. And it seems that as a lone procedure, stand-alone procedure, it's not so effective at all. You see here two smaller case series which have been published, and the pressure came down to between 15.3, but there's only 6 eyes, and a larger with 19.9 millimeters of mercury. So far, the only prospective data actually we have is from the UK study, including 45 eyes. which had a post-operative IOP, however, only at 6 months of 16.7 millimeters of mercury. However, it seems to be, again, popular in combination with phacoemulsification. You get a slightly lower IOP, and there's more studies on that. At this point, I'd just like to emphasize, which is probably all clear, but phacoemulsification is probably the most commonly performed procedure to lower IOP at all. And any procedure which is combined with phacoemulsification just lowers the pressure further down. Regarding complication to the eye stent, again, high FEMA is up to 70% seen. There are sometimes IOP spikes due to the viscoelastic used to form the anterior chamber. And there's some stent-related complications such as obstruction, inability to implant the stent, or just malpositioning. So to summarize the first procedures, these are definitely minimally invasive procedures. They have a short operating time. For that reason, they're very well combinable with phacoemulsification, as I said before, and increasing popular for cataract surgeons going into the field of glaucoma. Also, another advantage is that there's no conjunctival manipulation, which would preclude any subsequent fistulating surgery if required. However, the inability to view the angle is a contraindication, and the further limitation is the limited IOP reduction, at least in the eye stent. Bob Weinrab, which is called one of the gurus in glaucoma, is that the minimal invasive procedures are also minimally effective procedures. But why there's limited IOP reduction? In my opinion, there are different reasons. First, we just have to recall that there's still some resistance to outflow at the level of the sclera, which was represented by the episcleravenous pressure. Second, regarding the trabectome, although the company shows you a nicely ablated inner wall directly of the outer wall, there definitely is some reaction to heat. And this is a picture of a post-mortem eye. Just confirms that in a dead human body there's no reaction, but for sure there are some reactions which have not been evaluated yet. And for the eye stent, it's probably just too small to be very effective. For that reason, some of the surgeons put already 2 or even 3 implants in to reduce the pressure further down, which you call nicely titration of IOP reduction. And the third reason, I think, we still have to, something which is known for many years but has been forgotten, that Schlemm's canal is not always open. It's very narrowed or even collapsed with adhesion between the inner wall. This you also clinically when you unroof Schlemm's canal. And all these publications, except the second one, are published more than 40 years ago. So this is like a forgotten fact. Just because of the last 30 years, trabeculectomy has been so popular, so we forgot about the outflow system. And this leads me now to my second part of the talk, the external procedures, which can also be summarized as Schlemm's canal surgery. So I will talk about canaloplasty with the suture stent, and then with the expander. Again, the idea is that we target the Schlemm's canal not only at one side, but actually 360 degrees. And this we do in canaloplasty with a flexible microcatheter. I use the iTrack 250, which is 2 lumen. One is for the laser beam to visualize the tip of the catheter, so we know where we are, because it's risky. We don't have a light, so if you go suprachoroidal, you may create hemorrhage and severe complications. And the second lumen is for injecting viscoelastic material, which we want to dilate Schlemm's canal. And after that, we put the 10 occurring suturing to distend the inner wall of Schlemm's canal. I'll just show you now the video, the last part, which is the most crucial part of the suture canaloplasty. May I have the video started, please? Okay, that works. So this is like the step before we close the flap. Schlepp's canal has been already dilated with microcatheter, and the 10-point suture looped into the canal. Now it's very important that we suture and tight the thread under tension, so we got enough distension, which increases outflow. As you see here, it takes some time, and this is, in my opinion, also the most critical, but also the weak part of this procedure. But for unknown reason, it works very well, actually. Because currently we don't know how much tension we have to put on the suture. So I'll talk later quick about that. Regarding results, canaloplasty alone procedures are very effective. We get pressures independent of the preoperative IOP down to 12.6 at lowest in the German group, and on average is about 30 to 40 millimeters of mercury, depending also on the surgeon experience. Again, in combination with phaco emulsification, we get a further IOP drop, average between 11 and 13 millimeters of mercury. So it's quite a potent surgery. Complications. The most feared complication is basement membrane detachment, which may happen, especially in the beginning, if you overdilate Schlepp's canal. So there's a rupture at the junction at Schwalbe's line. Suture cheese wiring, which has been commonly voiced with concern in the past, is actually not a complication. And again, the typical complications related to glaucoma surgery are virtually not seen due to this approach. I didn't show, but I must emphasize that superficial flap is suture tightening, because we don't want flap formation, and we want to force aqueous to leave through the internal physiological outflow system. So, as mentioned before, limitations are we don't know exactly about the right suture tension, although it works quite nicely in the great majority of patients. And for that reason, it is not reproducible from a scientific point of view. And this is a slide I got from the multi-center study, which is not published yet, but we see that independent of the distension by the suture, it is actually very important that we have dilated Schlepp's canal largely. So at 250 microns dilation, this patient had the lowest pressure at last visit. And this leads me now to the concept of the expander, which I'd like to introduce to you now. It's like in analogy to stent surgery in coronary artery surgery. First we have to localize the pathological site, which is in our case Schlepp's canal. Then we dilate it with viscoelastic material compared to a balloon, and we implant then the expander. I also have a video on that. It just shows you the implantation of the canal expander. May I have the video, please? So this is the last part of the dilation with the microcatheter. You see here viscoelastic material effluxes from the canal. Now this is the torquer, and this is the 6-point suture which is connected to it, loaded with the canal expander. The expander has a length of 9 millimeters, so we can cover 1/4 of the suture. Okay, actually two on either side into the ostia, so we can cover 180. I usually prefer to implant first or insert the 6-point suture, and then I gently push the expander into the canal. Then I secure the expander while retracting the 6-point suture. This is on the other side. This may also take 2 minutes, but it's definitely reproducible. Because either you can implant it or you cannot. There's only 2 options. Thereafter I excise the deeper flap and close the superficial flap as in canaloplasty suture. This is how it looks like after surgery on gonioscopy, and on the right hand side on high resolution ultrasound biomicroscopy, where you can see even 12 months after the luminal Schrems canal is widely open. This is a video. Play the video on the right hand side, just high magnification of the canal expander. May I have the video, please? I mean, you can see it actually quite well, so maybe skip the video. This is on histopathology. On the left-hand side, you see a normal Schrems canal, not a glaucoma. It's a diameter of 120 microns, or the width of the canal is 120, and the stegmal canal is 140 microns. This is important to see that at least, also in post-mortem I do not traumatize the wall of Schrems canal at the time of surgery. These are just some preliminary results we had. We're going now for 2 years, but the pressure continues at the level of about 13 millimeters of mercury average. And the success rate for decent IOP reduction below 16 is 86.4%. So we can conclude external but also internal sutures are quite effective. It seems that canaloplasty is the most effective one of these 3 I presented to you. Probably also due to the fact that we target Schrems canal 180 up to 360 degrees. There is a combined with phakic emulsification. They're very suitable in patients which have a high risk for hypotony or bladder-related complications, which is an advantage of patients with enhanced conformation. So it's very rewardable. It's very good for the patient to relax after surgery, and visual recovery is quite rapidly too. And also, there are few complications. We don't use any metabolites to create late complications on the conjunctiva, visual recovery, and there is easy postoperative management because it's bleb independent. I usually see the patient on day 1, and then on day 7, and then every 2 to 3 weeks, which is unusual, or would be unusual for a checkup. It's also good for you as a surgeon. That's why I like this procedure. You can sleep at night. You don't have to think about the next day. You may also operate on Friday, but you don't have to handle complications. So I thank you for your attention. And as I'm a great fan of ice hockey, I did last year. I played. Okay, thank you very much.